Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I am your host, Jonna Emil, and joining me again is Dr. Sally Miller. Dr. Miller, thank you for joining me. Thank you for your time today.
It is a pleasure.
Yes, it's a pleasure for me to always have you listen to these stories. I got to tell you, this is one of the really fun things I like to do, listen to these stories, because not only is it like, whoa, can't believe that happened, but whoa, I learned a lot. And that's really the goal of these podcasts. And I hope all of you listening are learning a lot too and can apply this to your practice. And just as a reminder, Dr. Miller is a faculty member here with FHGA and an expert witness. So she actually serves as an expert witness on some medical malpractice cases that specifically involve NPs. So we're going to talk about different stories. Say we got a story for you, and it's where we break it apart, kind of walk through the timeline of events and think about where things kind of went a little off the rails, right? And maybe choose if we can identify different choices could have had potentially maybe different outcomes. But huge, big thing we want to always make sure to keep clear is that mistakes happen, right? So this is not us passing judgment on anybody, on any clinician, any practitioner. We all work in healthcare in some capacity, and we are all very well aware that mistakes do happen. They will happen to any and every single one of us. And so if we can learn and we can be better and do better and practice safer, we definitely want to take that opportunity for ourselves and to help you to do that too. Did I miss anything, Dr. Miller?
I don't think so. I was just, thinking when you were talking about, and when we talked about this in another episode that I hope everybody will watch, but yeah, sometimes mistakes, it's a mistake. We are human, and therefore imperfect, right? So we do make mistakes sometimes. And then sometimes they're not a mistake. And then sometimes what happens, you really just can't fairly characterize it as a mistake. Sometimes it really is a deviation of standard of care. Yeah. And I might have given away the farm here, but as we listen to this story, keep in mind that sometimes we have to step back and revisit what is the standard of care, because sometimes you can get caught up, especially nowadays that there are so many healthcare organizations that are for-profit organizations, and emphasis is on productivity, getting the numbers through. I mean, you hate to say it, but that's just the way it is. It's a business and it's a capitalist society, and somebody's getting reimbursed somehow, some way for the care. And if it's clearly a for-profit organization, there's an emphasis on numbers. We like to think there's an emphasis on quality, but getting people through. Lots of nurse practitioners, they are part of their salary is incentive-based or bonus-based. I mean, there are some of these very complex bonus structures here. If you see X number of visits, you get this much more over and above your salary. Oh, yeah. And when that happens, when time is the issue and emphasis is on productivity, you see things over time get really skimmed down. And it's not, I never think that anybody starts out this way or just tries to not do stuff, but over time, the longer you're in an organization, you see your peers skim stuff down. You got to get home before 10 o'clock at night, and it's like, so we'll trim this down, and I think that might have something to do with what happened here. So in this particular case, I as I look at it, and I really look at these through the most very objective eyes that I can, recognizing none of us are objective. That would have to be a machine, but I really try to be objective. And this is one of those ones where I don't think that any of us could really characterize it as a mistake, a single omission or a single misinterpretation. There's a real pattern here, but I can see how the culture of an organization can foster a very narrow approach to the patient, very limited timelines, and that's how this kind of stuff can happen. So looking at it through that lens, here is the story. Again, we're going back some years here because those are the cases that I can share with you, those that have fully resolved. Right. So this actually goes over the span of 3 years. This is 3 years. So Put on your seatbelt. Put on your seatbelt. This might take a little while. I try to be concise. All right. Starting off in April of year one. This is the first time that there is any documentation of this patient and this provider at this practice. So I don't know if she came in from another practice or what happened, but starting off in April of year one, a patient comes in for what is documented to be an annual exam, PAP, and cultures. So an annual women's health exam, presumably annual exam, PAP, and cultures done. So the charting is really very difficult. There's very, very little here to read. And, in school, you're taught to document your chief complaint, your history of present illness, all your history, stuff like that. I mean, there's a reason for that. And I'm a realist. I know that you don't always have 5 hours to do these big, exhaustive histories, but especially for an annual exam, we really do try to have some attention to those major features of the visit. What is the chief complaint in the patient's own words? Annual exam, PAP, and cultures, like that could serve as that. The next piece of the chief complaint here is culture of lesion at the introitus. So she has a lesion. She's got a vaginal lesion.
Yeah.
And she's here for an annual exam and PAP. Okay. That's our chief complaint. But there's virtually no history of present illness here at all. So if you're seeing a patient for a women's health visit and the chief complaint includes a lesion, a vaginal lesion, that's what she's got. In this first visit, there is, how do you work up a lesion? How long has it been there? Has it grown? Has it changed character? Does it hurt? Does it burn? Does it bleed? Have you ever had it before? Does it come and go? Like there is a trajectory of how you evaluate a new onset lesion. And even if you don't get all of it, we'd like to have some of it. There was no elucidation here on the lesion, just that it was cultured. So it is a pretty distinct deviation from standard of care. I'm not sure why. It might be that she collected some of this info and found it benign or negative or irrelevant and didn't write it down. Again, I'm really not trying to critique the care here, but paper is what matters. Paper like computer, but what's on paper is what matters in a lawsuit. And there was nothing here about the history of present illness. It wasn't asked about sexual activity. Is she monogamous? Is she asexual? Has she never had sex? Now, she was a 61-year-old woman. I identify with her too, but that doesn't mean there are 61-year-old women out there that have not had sex, believe it or not, or those that haven't had it in so many years as to be functionally irrelevant. But it's part of the history. It's part of the history of the vaginal lesion, and none of that there's just nothing documented here. The only thing that's put in the place for history of present illness was that the patient used an antibiotic ointment. It doesn't even say if it helped or it didn't. There's nothing there. So that's that. That's the history part of this exam that we don't really have. Next, the physical examination. It notes vaginal ulcer. That's it. Vaginal ulcer.
Okay.
Nothing about even the specific location, the diameter, the character of the border, the depth, the presence or absence of drainage, the presence or absence of pain to the touch, regional lymphadenopathy. And I'm not suggesting that every patient we recite a perfect textbook regurgitation of everything we're supposed to say or look for, but there was nothing there. I mean, she just noted vaginal ulcer. And well, any ulcer, there's lots of things that can cause them. Some of them are self-limiting and benign. Some of them are really dangerous and cancer. And there just needs to be at least a minimal history and physical here, and it just wasn't documented. There are a bunch of test order. There's a bunch of screening for an STD, things like gonorrhea, chlamydia, stuff like that. And the patient is instructed to follow up in a year.
Okay.
So follow up in a year does send a message that the ulcer is not a particular concern.
This is fine.
Yeah. It gives a message. Again, patients hearing things through their filter. So that was in April. Now, 2 months later in June, the same year, the patient actually did come back to review her lab results. So 2 months later, here she is to talk about the results of her, of her lab screening, her PAP and that kind of thing. The chief complaint is documented as, quote, review labs, comma, ref for a mammogram. And that's the chief complaint. There is no other documented history of present illness. There is no documented physical exam, including an exam of the lesion from last month. I mean, there's no
Oh,
documented physical
geez.
exam at all. This is just like let's go over the results of your labs. There is a diagnosis for this visit. The diagnosis is herpetic ulceration of the vulva.
Oh,
She got a prescription for acyclovir with an order to follow up in 6 months. So
okay. So
that's
they're
that.
saying it's herpes. That's what they're saying.
Yeah. Yep.
Okay.
And so there are, like, just to be clear, there are times sometimes in a clinical setting where patients do come back in to follow up on a lab, and we don't do a physical exam. Like if
Mhm.
if you had a visit, you did your your annual lipids and the hemoglobin A1C and whatever else we do. If they come back to review, we don't necessarily do a physical. We just sit there and have a combo.
Oh, yeah, right.
In this circumstance, just because she was diagnosed with herpes, this is 2 months later. Like the first visit was April, and this is June, and herpes outbreaks don't last for 2 months.
Yeah.
I guess unless the patient is severely immunocompromised. But if it's still there 2 months later, you have to revisit that
Yeah.
diagnosis. But there's no discussion of it. There's no discussion with the patient about, is it there? Is it better? Is it worse? Are there more? Are there less? Or a physical examination. So we just don't know. So she was told to follow up in 6 months, not even like if this improves or it doesn't. Like if she gets acyclovir, even assuming it's herpes and she gets acyclovir, you would at the very least advise her to return if it doesn't clear up.
Right.
I mean, again, in retrospect. So that's that. So we had April and June of year one. Patient isn't seen again. Well, she's seen several times over the next 2.5 years. She's seen again in January. So like 6 months later, there is absolutely no reference to anything to do with that. She's seen again 2 more times in February. Nothing about that.
Hmm.
She comes back in May. So May is 11 months since the last time she was diagnosed with herpes and given
Yeah.
acyclovir. And so at this visit, there is documentation of an outbreak of herpes for over 6 months. The bumps getting bigger, taking acyclovir with no improvement.
Doesn't sound like
So that's the history of present illness, right?
Okay.
There is a brief and essentially useless exam of the genitalia documented. It's not an internal, like not a speculum exam or a bimanual exam. There is an inspection of the genitalia, and it documents a normal external genitalia, but a genital wart. Now it's calling the thing that was an
Oh,
ulcer a year ago a wart now. Again, no size, no measurement, no character, no nothing. The patient was given a prescription for Aldara cream. So it's like, to debride a wart, like for
okay.
HPV. So that's that. Follow up in 3 months if it's no better. At least at this time, she was told to follow up if no better. Now, the patient, I should probably also say, has diagnoses of multiple comorbidities, isn't the most adherent, or perhaps, I don't know, what's the best word here? Maybe really doesn't fully understand the implications of some of the things she's told, doesn't follow
Okay.
up as aggressively as she's necessarily told to, things like that. And
Okay.
again, that's the patient. We're the examiner. If we think something is really critical to evaluate, we have to be clear about that, as clear as we can, and document that we were as clear as we can. And if the patient doesn't follow up, then that's on the patient. So this was in May of year 2. We have a 6-month outbreak of herpes with no improvement. Now it's a wart. Now it gets Aldara cream. So the patient comes back 3 months late. Wait, look at the time frame here. That was May, June, July, August. 4 months later. I have to count on my fingers again, like the academic that I am. Patient comes back 4 months later, and the patient says she did not use the cream.
Okay.
And the MP said, okay. Basically, there was no further, well, why not? Is it getting better? Because the patient has other issues and the patient's here for like, med refills and stuff like that. So
Right.
kind of in passing, apparently, the NP asked, did you use it? And the patient said no. And that was that. There was no, well, is it getting better? Is it getting worse? Is it more of them? Like nothing else. That's just it. That's the end of that discussion. There is no exam of the lesion at this point. There's no genital exam. Actually, nothing now about facilitating further evaluation of this thing that now is almost a year and a half old.
Jeez.
So then we have another totally unrelated visit the next month. Some other physical ailment. No question or nothing. In February of year 3. So we had year 1 was when it was first diagnosed as herpes, and then a few months later it was given acyclovir. And now we're a year later. So now we're almost 2 years. Went from May of 1 year to February of 2 years later. The patient comes in for a physical exam, and the physical exam is very detailed, except for the genitalia. There is no, now it doesn't say that the patient mentions it either. But again, as the professional, if we're doing our annual exam, you typically follow up on existing or outstanding phenomenon. And there was no questioning, hey, did it ever go away? Is it still bothering you? And there was no physical examination. So that was that. The patient comes back in October. So this is a bit of a stretch here. We went from February to October. Now the patient comes back in October, 2 years and 5 or 6 months after the initial complaint, complaining that the vaginal wart, we're calling it a wart now, is still there, and she's developing boils on her inner thigh.
Oh my goodness gracious.
So now the reason for the visit is the vaginal wart and boils on her inner thigh. There is no history of present illness about this vaginal wart. Like, well, is this the one that was there 2 years ago, or is this another one? How long, progression, again, nothing there. But more interestingly, there is no physical examination of the genitalia. Now, the reason for the complaint is the wart and boils on the inner thigh, and there is no physical exam documented of the genitalia, and there is no diagnosis related to the complaint. The outcome of this visit was a medication refill for her chronicities. So there's a take. I mean, again, I'm really just the takeaway for anybody listening, and you do learn this in school, and then it's easy to forget it. Most of us, it just becomes second nature. But a chart should read like anybody else should be able to read your chart from top to bottom. The chief complaint is why they're there. That informs the history of present illness. The history of present illness is to evaluate the chief complaint. And then you get as much info from the history of present illness, and then you do a physical exam to further narrow down potential causes of your chief complaint. And then if you need to do labs, you do it. And then your diagnosis should derive from the history and the physical.
Right.
And we just don't see that here. Like there is no diagnosis related to the complaint. There's no plan related to the complaint. What this really turned out to be, it was treated as another chronic visit because there was dyslipidemia and hypertension and, diabetes and that kind of stuff. And that's ultimately the stuff that was addressed at this visit. So that was in October. 2 months later, the patient comes back. She is now complaining about the wart that is overly symptomatic. She says it's getting really big, that it's starting to hurt, that it's starting to look different, and it's starting to scare her, the patient. So this time there is a history of present illness documented, but there's no physical exam.
Oh, what the heck?
There's no exam. She doesn't look at the vagina. The diagnosis for this visit is herpetic vulvovaginitis.
So we're back to that.
Herpetic vulvovaginitis. I'm not entirely sure. I mean, that might be a word. It might be ICD-10 code. I'm not entirely sure. And listen, some of your listeners might. I've never used that phrase. I mean, it's because there's herpetiform lesions that are not herpes. So herpetic doesn't necessarily mean herpes.
True.
But is it herpes? I don't know. So, but she was diagnosed with herpetic vulvovaginitis and referred to dermatology.
Derm.
which, yeah. So, I mean, that, yeah, again, I mean, derm typically handles skin things other than those of the genitalia. I mean, I
Yeah.
would think that you would refer this to GYN, but hey,
Yeah.
at least there was a referral. Okay. That was in December of year 3. So this is 2.5 years after the original presentation. So that was December. For the next couple of months, the patient never goes back to this practice or this clinician, but she's in and out of the emergency room because these boils that were reported and never examined or addressed. She finally went to the emergency room to have the boils on her inner thigh drained. And I mean, they were big and drained and packed and stuff. And then she had to
Packed.
go back to the emergency room. Yeah, like they were deep enough that they had to be
Wow.
packed after they were drained and irrigated.
Wow.
And then while she was in the emergency room and somebody was handling these boils, they apparently saw this enormous lesion of the vagina and called a GYN consult. And the GYN consult referred the patient for surgical biopsy. So we've got a period of time here, like this is December when
Mhm.
that's the last visit, and then over December, January, February, the patient, it takes a while. Like a few weeks later, she goes to the ER, and then she's got these abscesses, and then they drain them and pack them and tell her to do stuff. And then when she comes back, and then somebody orders the GYN eval, and GYN says, "Oh my goodness, this needs to go for a surgical biopsy." So then, by the time the patient schedules the biopsy, we're into March. So it's March now.
Oh my gosh.
Um, the patient goes to have her biopsy. Oh, by the way, when she got the referral for the biopsy, the lesion was 5 by 4 centimeters.
Wow. That's big.
5
That's
by 4,
big.
not millimeters, 5 by 4 centimeters.
Wow.
Um, she had her biopsy, and she was diagnosed with metastatic squamous cell carcinoma,
No
and
way.
she was referred to oncology. And she got under oncology care. And while she was at the oncology office having a visit, she developed acute shortness of breath and symptoms. Oh, I'm going to sneeze. Bless me. Keep you on the edge of your seat, right? That wasn't timed on purpose. While she was at her oncology visit, she developed acute symptoms, and they called an ambulance and took her to the hospital, where she died in June. So she died 3 months, March, April, May, June. She died 3 months later. And the death certificate noted the cause of death as metastatic squamous cell carcinoma of the vagina.
I have not ever heard something like this before.
So, I mean, I really, even still, I really do feel compelled to emphasize we're not being judgy. I mean,
No,
it's easy
no.
to look at this and go, "Well, how did this happen? How did this not happen?" But like I said, like it's almost like people always tell me I'm nuts when I say I don't think Bernie Madoff started off to have this $1 billion Ponzi scheme. Like
Mhm.
stuff, it is the nature of the human condition that you have small exposures and cut a few corners, and then it's easier. So the next time you cut a few more. This was probably a practice setting that really encouraged volume and turnover. And it wasn't a women's health setting. It was a general setting, but they did paps and pelvics. So, but the genitalia wasn't the focus of most of the visits. It was her chronicities. And so I mean, in retrospect, certainly there's things that, we like to think, wow, going forward, we'll make sure that we don't make some of these errors. But I just think it starts out with okay. So you're here today for women's health. We offer
Right.
that here at this family practice. Okay, so we're going to do this. Say, oh, well, I don't know, a lesion in the vagina is probably herpes, like that. Like I
Right.
could just see stuff going that way, and then in follow up, well, if the patient doesn't mention it, so the provider doesn't mention it, and then like again, there's things that really were done here that probably could have been done differently. But I don't think anybody starts out to be purposely disregard and deviate from standards of care. But as
Yeah.
we look at this story, there are certainly some big takeaways for all of us. I mean, and the thing that I think is consistently missing in all of these is just that trajectory of chief complaint leads to history of present illness, which leads to physical exam, which leads to diagnosis. And I think if that stuff had been done, it might have been evident much earlier on that there was, a problem here. Like ulcers, yeah. Could a vaginal ulcer be herpes? Yes. And then in a
Sure.
few days, there's going to be more ulcers and more and more. And then in a week or two, they're going to dry up and go away, you know?
Yeah.
And if it's
Yeah.
still there 6 months later, it is not herpes. If an ulcer is still there 6 months later, like squamous cell carcinoma anywhere in the body is like your leading differential,
Yeah.
you know, for anybody, anywhere in family practice. So there's definitely some things that we can learn from this.
Yeah, a ton. I mean, I really this was a doozy. And I agree. We don't want to be judged. We don't do that, right? But
Mm,
for sure, like listening to this, Dr. Miller, I mean, like it's not, dare I say, it's not difficult to be
mhm,
objective in the sense of like there was an actual an actual problem
mhm.
almost
Yeah.
literally staring you in the face that you didn't address. You never addressed it. And what a awful outcome. What a terrible outcome.
It was a terrible outcome, and and preventable for sure. But I also I always try to get in the head of when I see something like this. It's like, oh my gosh, things are often not what they seem, and I try to get into the head. And I'm not that it matters from a testimony perspective, but just
Right.
trying to understand how this happens. Like I can almost see a dialogue where the NP says, "Look, this is out of my area of expertise. You
Yes.
need to go to GYN." And the patient says, "No, I don't want to. I can't. I don't like them. I don't have any transportation," like 100 litany of reasons why I can't go. And then maybe the NP says, "Well, look, I can't manage this. You have to
Yeah.
go. So I'm not going to examine it and I'm not going to treat you." Like, but didn't write it down. I mean, I
Right.
don't, I think there could be a whole combination of things going on here. We're just seeing what's on paper,
Right.
which doesn't always necessarily tell the story, but clearly there are takeaways from this for all of us. And like, if nothing else, if that's what happened, it needed to be documented.
Yeah.
100%. If that's what
Yeah.
happened, it needed to be documented. Um, to document herpes for 6 months, I mean, that definitely does demonstrate a knowledge deficit
Yes.
about herpes. That's just that's
Yes.
not the way herpes presents. Um, to recognize that ulcerations, if they don't resolve, ulcerations are, you have to consider squamous cell. Like there's several learning things going on here. um and
And
she's my
like
age, so
the
she's not an old
aceclivir.
lady.
Right, and then the
Hmm.
aceclivir not working, I forgot the name of the cream, for the wart cream, like, not working, all of those
Aldara,
things,
yeah.
Aldera, and all of that not working, and still she's having these symptoms happen, these lesions happen, like,
Yeah.
come on. That's
Listen,
frustrating.
I'll bet that this NP probably looked back at her chart and said, "Oh my gosh." I mean, I've looked back at my charts, thankfully
Yeah,
not in the setting of a malpractice case, but I mean, I've looked back at some of my charts on a really busy day. I've looked back and, "Oh my God, did I do that? Did I not write that?
yeah,
Like, did I do that?" I mean, I
wow.
don't think ever quite to this extent, but only because I've done so much of this work that at this stage of the game, I really am on my documentation game. But I do. I mean, I hope that we all can look at this and say, man, there's
Mhm,
so many things here, and I think probably from the perspective of the MP, it's not as dramatic as it sounds. It's not as dramatic as the documentation, but there's a lot of teaching points here, and that's surely one of them.
there's a ton, my goodness. So I'm gonna say, so far, I think I'm batting a really good average. I'm gonna say that you were on the plaintiff's side.
I don't think that's a tough I don't think that's a tough read on this one, but yes. Yeah.
Wow. Yeah, how unfortunate. How unfortunate. But I mean, there was a lot to
Mhm.
learn on that one. I mean, absolutely. And I think you make a really good point about like, just really being mindful and being careful about one, documentation. You always bring that
Mhm.
up, and that's super important, documentation. And if these cases and listening to these cases isn't like enough proof to you that you really got
Mhm.
to be good about documentation, like then we got to do more, right? And then yeah, being really careful about those shortcuts. And wow,
Man,
sometimes we get comfortable to a fault.
if I had a nickel for every time a patient's like, "Oh, I don't really wanna do that. Can I just do
Mm,
this?" Or, "How
mm,
about if I do that?"
mm-mm.
And I say, "No, no,
No.
I'm sorry, can't support it. Nope." No.
No.
And if you want to transfer your care elsewhere, I would totally support that,
Yeah.
you know?
Yeah. Well, Dr. Miller, can you tell us what the outcome was for the NP in this case?
Um, yes.
Or like the case itself? Like, did it settle? Like, what
Yeah,
happened?
yeah, yeah, yeah. No, there was a settlement.
Okay, there was a
This was a
settlement.
settlement.
Okay.
Yeah, and
Yeah, got it.
the NP did settle this one, and but the NP, yeah, is remains out there. It remains
Wow.
practicing and stuff,
Yeah,
and I don't know if there were any, I don't know if there was any um required remediation or anything like
right.
that. But yep, yeah, but yeah,
Wow.
it settled on behalf of the family.
Wow. Oh my gosh. Dr. Miller, thank you so much for sharing this case and those takeaways. This was this was a lot, but that was,
Mm,
I mean, a really, really good, like, this is the reason why we do what we do and why
this
we
is
talk
this.
about this.
And it's all fine until it's not. You
That's
can go
it.
years and not have a problem, and then all of a sudden it's not fine, you know?
Yeah, you're totally right. You're totally right. Man, wow. I
Mm,
appreciate your time, Dr. Miller. Thank you
sure.
so much.
My pleasure.
And we hope you enjoyed listening to this and got some really good takeaways from these stories. All the stories that we talk about here in Scrubs and Subpoenas, hoping that you can take those. Let us know how you're enjoying it. Check us out on FHA.com for more of our episodes and more resources. And you can connect with us there if you have any requests for some more of these bits and tricks, some of the things that we'll talk about as well. In the meantime, hope you guys enjoy, and goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.